Good evening, and welcome to Doctors on Call. Tonight, our panel of medical experts will be taking your questions about lower GI problems. So what would you like to know about issues ranging from hemorrhoids and constipation to colitis, diverticulitis, and colon cancer? I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School here in Duluth, and I'm your host for tonight's program. We're ready to take your questions. Give us a call locally at 218-788-2844 or toll free at 1-877-307-8762. I'm pleased to welcome our panelists this evening. Dr. Bradley Irwin, a gastroenterologist with St. Luke's Gastroenterology Associates. Dr. Addie Licari, a family physician with St. Luke's P.S. Rudie Medical Clinic, and Dr. Ayan Rage, a gastroenterologist with Essentia Health-Duluth Clinic. Our medical students answering the phones tonight are Elena Hinsela of Duluth, Minnesota, Maya Johnson from St. James, Minnesota, and Madison Wigg of Worthington, Minnesota. And now on to our program this evening on lower GI problems. I think it's probably good once in a while just to kind of refresh our audience about our specialties and what we do. So Addie, Dr. Licari, could you tell us a little bit about your training as a family physician and the kind of people you see?
So I went to medical school, as did all of us here, for 4 years. And then I did a family medicine residency. And a family medicine residency actually involves all scopes of medicine. So we see patients from the cradle to the grave is one of the sayings. I see children all the way through to elderly patients. And our training involves usually rotations with actually specialists who teach us the intricacies of their specialty for several weeks at a time, and we sometimes go back and do more training with them. But in the end, we're supposed to be fairly well-rounded basic education in sort of all aspects of general health.
Dr. Rage, let us welcome you to Duluth. It's nice to have you with us and introduce you to our viewership. Can you tell us a little bit about yourself and your specialty?
Yes, so after medical school, training and residency in internal medicine, I've decided to specialize in gastroenterology and hepatology, which I've done for 3 years. And this is focusing on disease that really affect your GI tract, from your food pipe, stomach, colon, and also the liver. So that covers a wide range of disease processes.
And Dr. Irwin, you've been with us before, but you want to tell us a little bit about your background too?
Yeah, just to echo, and I'm sure our training is very similar. When we, after internal medicine, go into GI fellowship, our duties basically at that point is we round on inpatients. A lot of our training focuses on endoscopy, doing colonoscopy, upper endoscopy. We get exposure to endoscopic ultrasound and ERCP as well. We generally make a decision then whether we want to practice general gastroenterology, which is what I do, or if you have a specific focus such as IBD or advanced biliary work, you may do a year and do those kind of procedures. So,
very good. Thank you very much. Dr. Licari, could you talk to us a little bit about normal lower GI function, normal lower bowel function?
Sure. So normal lower GI function can vary depending on the individual, and people often come in wondering whether their function is normal or it's abnormal, and actually that differs from person to person, and it can differ throughout the lifetime from young children all the way up into older persons. So it is normal to have a stool every day. It is normal to have a stool every other day. Some people, it's normal to have a stool every 3 to 5 days. The big things are that it should not necessarily be a painful experience or an uncomfortable experience. And regular is all sort of relative to what is typical for you.
So then how do we define, and any one of you can grab this, how do we define constipation?
So I was just going to jump in. It's just we usually use the rule of normal bowel movements as being 3 bowel movements a day up to having 1 bowel movement every 3 days. You can think of the 3-in-1 rule.
3-in-1.
So that's the range of what's considered normal. And like Dr. Addie said, that any of these levels are okay for the person. But constipation, it's really when you have straining, hard stools, feeling uncomfortable, and after you've had a bowel movement, having the feeling that you haven't completely evacuated. So those are the kind of the symptoms that I try to, gauge for my patients when I'm seeing them in clinic.
So Dr. Irwin, what should someone do with constipation? Are there things that a patient can do to help that?
Sure, I think diet plays a role. I think one of the things I talk to about my patients, if they've come in and suddenly had a change and they're now constipated where they weren't before, I focus on diet. Have they changed their diet? That sometimes changes consistency, moisture content of stool. Medications, I focus on that a lot. Have they started new medications that are constipating? Look for simple clues as to why something's going on. Outside of that, then there are certainly organic problems or health problems that can lead to constipation. So we start screening or thinking about those things with patients. Certainly can be structural things that lead to constipation as well. Thankfully, not quite as common. So kind of just go through a list of things that can lead or cause constipation with patients. Things that they can do to prevent or treat it at home, simply increasing fluids, increasing fiber. Sometimes that helps to cure or fix their constipation. Then after that, a lot of times they come and see us to see what's going on.
Dr. Licari, what kind of things, as a family physician, what kind of things as far as bowel habits in the lower bowel concern you and would want you to look further and evaluate more?
Yeah, so I think there's, like Dr. Irwin said, there's a normalcy that most people know, and a significant change in that normalcy, particularly in patients who are above the age of 40 or 50. That is a reason to come to your doctor and get things checked out. We always worry about blood in the stool, and it's one of the first questions we will ask patients. Do you have blood in the stool? Do you have mucus? Do you have dark stool, which can indicate actually that there's bleeding further up into the GI system?
So as long as we're talking about blood, generally, as I think of practice, usually when there's bright red or red blood, you think hemorrhoids. What are hemorrhoids?
Yeah, hemorrhoids are actually very common, and they're just engorged, blood vessels there in the anal canal. We try to differentiate from internal and external hemorrhoids. Usually, some of them we are able to see from the outside, and others only through doing a colonoscopy and looking further you could see. Hemorrhoids do indicate that you've been probably straining or having hard stools, so they're more of a reflection of underlying bowel habits. In itself, they do not are not problematic, but if they're certainly bleeding or causing itching, certainly that's something that you want to tell your doctor and investigate further.
So one of the things that we're always concerned about, of course, is bowel cancer, and as long as you brought the C word up, colonoscopy. What's a colonoscopy, and what do you do with that?
Irwin, do you want to take that?
Sure,
Go ahead.
sure. So a colonoscopy simply is the colonoscope is simply a device with a light and a camera. When patients come in, say for a screening colonoscopy, they spend the day before on a clear liquid diet and take a bowel prep, which essentially flushes the stool from their colon. They come in, most often receive some form of sedation, and then we basically insert the scope in the rectum, advance it to the beginning of the colon, which is on the right side, typically where the appendix is, and then come back out. And in that process, we're looking at the lining of the colon, inspecting it for polyps, making sure they don't have colon cancer or other mucosal abnormalities within the colon itself. So pretty simple procedure. Doesn't take a long time. It's a safe procedure. And I think our experience now over the past 25, 30 years is it shows that it's greatly reduced colon cancer. We've been able to diagnose colon cancer at a very early stage and treat it and cure it actually, versus days past when we didn't do screening colonoscopy and people developed colon cancer and passed from it.
So how about that camera thing? You swallow the pill. What about that?
I mean, that certainly can be a way to look at the colon.
You still have to do that prep?
Exactly,
Yeah.
you have to do the prep, and if you do find something there, if you find a large polyp, you would still need to go through the colonoscopy, because the colonoscopy can not only diagnose, but it could be a therapeutic and remove polyps before they turn into cancer.
Addie, as we talk about this, one of the questions is, what are the symptoms of colon cancer? And really, I guess my feeling in your discussion, it's a change from normal. And there's nothing really specific, is there?
There is not, and actually patients can have colon cancer and not know it, which is why we
Absolutely.
recommend that at age 50 for average risk persons, you start with your screening colonoscopies, because it takes about 7 to 10 years for the average polyp to go from just a polyp to a precancerous polyp to a full-blown cancer, and that's why we do the screening every 10 years versus a longer period or a shorter period of time. If you have a family history of colon cancer, actually the screening recommendations are much closer together, somewhere between every 2, 3, or 5 years, depending on your risk factors.
So if you're on blood thinners, how do you handle that with blood in the stools? Does that change the way you look at the possibility of bowel cancer, or doesn't it?
I don't think it necessarily in the beginning changes.
You
know,
still go look.
There's still blood in the stool.
Right.
And why is it there?
And why is it there? And I would say more often than not, there is a more benign reason that we do see as the cause of that bleeding, but we still worry just as much as the person off blood thinners regarding.
Right.
It's still important to look, even if you are taking blood thinners. It's not normal to see blood in your stool, and that's certainly something that needs to be investigated. And while we're talking about blood thinners, it's very important, especially aspirin. If someone is on aspirin because they need it for heart protection, or they've had a stroke, or you've had a pre-stroke, what they call that TIA, it's important that you do not stop your aspirin even if you're going for a procedure like a colonoscopy, because the risk of having a clot is greatly increased versus bleeding from a procedure-related colonoscopy.
Dr. Irwin, antibiotics, do they raise havoc with the large bowel?
They can. Certainly antibiotics, I think most folks are aware that antibiotic use can lead to C. difficile colitis. By reducing the normal flora, the normal bacteria count, other bacteria sort of take over and create problems. So antibiotics certainly can do that. There's also antibiotic-associated diarrhea it's more related just to reduction of normal bacterial counts.
Well, thank you for that, because I wanted to go into probiotics.
Okay.
There's been a few questions on probiotics coming in. Do they make a real difference with diarrhea, and are there recommendations regarding the best probiotics? And I'll leave it open to the panel.
I mean, there's several studies that have tried to pin that down, and really there's been no clear evidence that the probiotics prevent C. difficile. That's our biggest concern. So they've been not shown to do that. If patients feel better, by taking probiotics, we don't tell them to stop it, but there really isn't a clear body of evidence to support that the probiotics are helping.
What do they do?
I mean, the rationale behind it is to we do have this flora, variety of bacteria that live in our colon. We consider them good bacteria. And when you get an infection like C. difficile, it's the bad bacteria taking over. And the rationale is hopefully you can repopulate your colon with the good bacteria. But that hasn't panned out, to show that these probiotics prevent C. diff or they prevent recurrence of C. diff. That has not been shown to be the case.
So Brad would.
I totally agree. I get these questions a lot. They're very popular. They're advertised on TV sort of as the panacea of bowel health. There's some data in certain patient populations like Crohn's patients where it might give you some benefit. In general, I don't dissuade my patients the same from taking them, but I don't necessarily promote them either.
Addie, give us a family practice way of looking at this one.
Yeah, and I agree that there are certain people who do truly benefit symptomatically from probiotics. My take on this is someone who sees patients who don't necessarily want medication all of the time, is that we have probiotics right there in our food supply. We have vegetables, we have fruits, we have other things that have actually these natural flora on them. We have greatly reduced this in the food supply by use of antibiotics in our food supply, by sterilizing everything. Some of these are actually mandated things, through the government. So we have them, and I do most of the time encourage people to use a more natural source of probiotics, such as fruits and vegetables.
Which give you gas.
Yes. If a person is going to use a probiotic, my personal opinion is that you can sell anything in a pill. The companies are out there to make money, and the process of drying and sort of producing these capsules isn't necessarily good for things that need to live like bacteria. So if I am going to have a patient take a probiotic, I often will have them use something that is refrigerated, or even products like kombucha or kefir, which is actually mostly lactose free, and some patients have an issue with that. So.
And again, the reason I threw in the discussion about gas, I think it's important for people to understand that having bowel gas is a normal phenomena. And I don't know what the right or wrong number a day is. It's there. And we had that little bit of that discussion earlier. So as we do this probiotic thing, we get into ulcerative colitis, some of the other things. What about stool transplants?
Well, we don't do them at St. Luke's, so I'll throw them over to my colleague where we refer patients to for stool transplants.
Yeah, so a stool transplant is basically taking a stool sample from one individual and putting it in the colon of another individual. There's several.
You don't do it by pill.
Correct. There's several ways to do this. Actually, you can do it through a colonoscopy, and then have the stool delivered that way. There is a way also to do it through an NG tube, but the way we do it at our institution is through a colonoscopy. And one of the main indication that we use it for is for someone that has had C. diff multiple times. And again, the theory is that you want to repopulate good bacteria in the colon. And there's a very rigorous screening process for the donor. And has been shown to be very effective in that small population. There's some studies looking at doing fecal transplant in ulcerative colitis, but that's, again, ongoing studies, and we don't have the results of that yet.
Thank you.
You're welcome.
Another question is having a bowel movement and then it's followed by a film-like liquid. Does that mean anything?
It can. I guess when people talk about mucus in their stool or some sort of coating like that, if there's irritation in the rectum and in the colon, it can certainly cause that phenomenon. But remember, there's glands that are normally present in the rectum as well. So simply mucus by itself doesn't necessarily indicate disease process. Other symptoms such as tenesmus, rectal bleeding, and other pain, change in bowel habits certainly would also add some suspicion to that finding as well.
Is it common for senior citizens to get hemorrhoids, Addie?
It's very common. The most common population to get constipated, I believe, is your gut slows down as you age. And we do see a fair amount of hemorrhoids in that population. The other population is pregnant women. They are basically varicose veins of the rectal area. So anyone who's at risk for varicose veins with other medical problems or disease processes also can get hemorrhoids as a result.
Can they walk them off?
Well,
they're asking the question.
I
don't know.
The biggest thing is to get rid of the inciting source of the hemorrhoids. And so if that inciting source is that you sit all day long or that you strain with your bowel movements and you need to treat your constipation, then getting rid of that certainly helps.
How would you treat it?
Our first step is to actually, for a non-inflamed hemorrhoid, is to use stool softeners and use diet to soften the stool so you're not pushing, straining. The itching is commonly treated with steroids or cortisone topically. We also want people to be keeping that area nice and clean and dry, and so that's a problem. As you start to get hemorrhoids, they actually form little sort of polyp-like things off of the anus. And so debris like stool and wetness, odor can get trapped under there and cause more irritation.
What about Miralax?
Miralax is one of the available stool softeners out there. It is actually, the chemical name is polyethylene glycol, and it's been around for years. Actually, Miralax just sort of marketed this product more aggressively in the more recent years. But it basically takes on water in your colon, much like a fiber may do. It has been known to cause some excess gas, so that's one of the downsides of using it. But it is a very it's considered a very safe thing to use, especially in kids, pregnant women, other people where using a stool softener or something more likely to cause pain or cramping is not wanted.
One of the questions that's come up, we talked about colonoscopies. Thank you.
Yeah.
That was very well done. We talked about colonoscopies earlier. Could the two of you on the ends here elaborate a little bit on the different preps and compare and contrast different preps for colonoscopy?
You want me to go first, or would you like to start?
Yeah, I'll let you go first.
Preps are preps. There's several sort of brand name preps that aren't generally covered by insurance that have touted lower volume. I won't mention the brand names on TV, but the idea is to drink less, more palatable tasting. But the downside is that you still have to drink an awful lot of clear fluids for them to work, because they all work, just like Dr. Licari said, by bringing fluids into the colon. Versus the old traditional Go Lightly, which was a gallon of really nasty tasting stuff. But ultimately, it's the volume of fluid that you're going to end up drinking that's going to essentially wash out the colon and make it well prepped. There are pills, there's different liquids and whatnot.
Does it always work?
No, not always.
Yeah.
For the most part, though, I would say at our institution, and I don't know about yours, we probably use the Miralax Gatorade prep as much as anything. It's basically 2 quarts of Gatorade mixed with Miralax, along with Ducalax tablets. It's cheap, it's over the counter. Is it great? No, but it does have pretty good results.
In addition to the prep, the type of prep, it's also how you take the prep. A lot of studies have shown that splitting your dose, meaning you take half of it the night before your procedure and half of it you taking the morning of the procedure. And I know this means that, as a patient you have to get up really early, but the good result is that you'll most likely have a better prep quality the closer you have the prep to your actual procedure. And this really means that we'll get a good look at the colon, see any polyps that are there, and have a better procedure.
Addie, from family medicine standpoint, what's the difference between having the colonoscopy done and then or sending in a stool sample, I suppose, for like a hemocult or blood?
Well, the obvious difference is you don't have to go through that procedure, but the studies have shown that colonoscopy is much more superior to finding colon cancer than a random stool sample. And I use it in the instance where a patient either can't medically undergo a colonoscopy or does not wish to do that and is fairly adamant about that. When we do a stool sample for blood, you can miss bleeding because you're only taking 1 or 2 stool samples in a period of time. If you have blood on your stool, you need a colonoscopy. So there's a fairly limited population I use that in.
Yeah. And just to add that, the stool studies are looking for cancer, whereas the colonoscopy is looking for cancer, but also polyps, which are pre-lesions. So you're catching things earlier, even before cancer develops.
What are diverticuli?
So diverticular are outpouching of the colon, for lack of a better word. And basically this entails increased tension on the colon wall from constipation and North American diet. A lot of us have them, and they don't bother us, but there's a small segment of the population where these cause problems, where they bleed, where they can get infected.
IBS, Crohn's.
IBS and Crohn's?
Yeah.
2 very
got
different
about a
things.
minute.
Okay, real quick. Crohn's is inflammation of the colon. It's a autoimmune disease. It causes significant pain, discomfort, rectal bleeding. It's actually a disease that can affect anywhere from mouth to anus. IBS is essentially a functional disorder. It actually represents hundreds of different things. Patients present with symptoms such as change in bowel habits, diarrhea, constipation, but it can also be pain, nausea, vomiting. Generally, when we say functional, we don't find an underlying organic cause for it. So we try to manage the symptoms the best we can.
Addie, any comments on that one?
Yeah, and I would say that the majority of patients that I see with IBS have other associated disorders and that go along with sort of that result.
This has really been an interesting discussion. I've got a handful of cards yet, and we could have gone on longer. But I want to thank you very much for this. It really was a great conversation. I want to thank our panelists this evening, Dr. Bradley Irwin, Dr. Addie Licari, and Dr. Ayan Rage, and our medical students and volunteers, Elena Hinsela, Maya Johnson, and Madison Wigg. There will not be a program next week due to Thanksgiving, and the following week because it's Pledge Week here at the station, and I'd remind you to think about donating to PBS. Please join Dr. Ruth Westra on December 10th for a program on ear, nose, and throat problems, when her panelists will be Dr. Todd Freeman, Dr. Jacob Pernuski, and Dr. Mark Rhodes. Thank you very much for watching. Good night.